I would like to give some basic knowledge about the how ECMO works and which situation, which type of ECMO you have to use, and the how circuit works and all. So I would like to explain it based on a case scenarios first of all. So we have various extracorporeal organ support system. For renal, you have CRRT, intermittent hemodialysis and all. But for cardiopulmonary support, we have either extracorporeal life support or uh, pump only mechanical circulatory supports. That is where you don't have oxygenator, you just have a pump which supports either right or left side of the heart. So, okay, and other immunological and hepatic organ support systems are there, but we'll mainly focus on the ECLS and ECLS. Okay, the extracorporeal life support has two components. One is either you are supporting the oxygenation of or both heart and lungs. Either you are supporting only the lung or you are supporting both heart and the lung. That is called extracorporeal membrane oxygenation, where there will be a membrane for the diffusion of gases will be there, where the CO2 oxygen is added to the blood and CO2 is removed from the blood. And other thing is extracorporeal CO2 removal, where it only targets to the removal of CO2 only, where the patients who are able to maintain their saturation but unable to maintain the level of carbon dioxide required, the higher carbon dioxide, especially the COPD patients, where they are able to maintain saturation with little bit of oxygen, but the amount of CO2 in build up is very high. In those patients, we will use the extracorporeal CO2 removal techniques. Okay. So first, let's come to a scenario where I first experienced my venovenous ECMO. So it was in Chennai MGM hospital where I joined as a consultant. In the night, 2 o'clock, patient came. He's a known case of ILD. He was on 2 liters of oxygen 4 years back, and slowly the oxygen requirement has increased. He had an attack of COVID. Then after COVID, his oxygen requirement went up to 6 liters. Intermittently, it goes up to 10 liters. He came to the hospital with a desaturation. He is on 15 liters NRBMS, and the saturation he is having is 83, 84. So we have taken him into the hospital. We have to admit it. He is already registered for the transplant. So we are waiting for the organs to come so that we can transplant the organs. So we have switched him to the NIV 100% oxygen with little PEEP and pressure support, but the saturations are not improving. So I asked my consultant, what should I do next for this patient? Should I intubate this patient? So my consultant said, don't intubate this patient, because if you want to intubate this patient, you have to give a muscle relaxants. His tidal volumes are already around 200 to 170 ml. If you give a muscle relaxants, his tidal volumes become 50 ml with your ventilator support also, and your patient will arrest immediately. Actually, that is one of the time which happened to me already once. So what we have to do in such a situation is that first we have to counsel the relatives that what are the options we have for this patient. Okay, so we go and tell the patients that okay, he requires a certain amount of ventilator support, otherwise he can't maintain because he's already on 100% oxygen on NIV. So but to ventilate him is also not possible, because as soon as you give a muscle relaxant, he is definitely going to crash. So we have to give an option of others lung support to therapy until he is some organ donor comes so that we can transplant the lungs for him. So we counseled him for the ECMO support, which we use here is the VV ECMO, and then we intubated him. Definitely his tidal volumes were only 100, CO2 was rising immediately. So we prepared ECMO circuit before intubation itself, and then we placed the ECMO. This is called venovenous ECMO. The venovenous ECMO, what we have, are you able to see the image? Okay. Okay. So this is called drainage cannula. So in the drainage cannula, usually placed in the femoral vein, and the tip of the drainage cannula will be at the level of hepatic vein. From here, the blood will be pumped by a pump, which is we usually use a centrifugal pump, but usually in your hemodialysis case you have a roller pumps. But if you use a roller pump in this case, that has to pump 3 to 4 liters, maybe up to 6 liters per minute of the blood. The pipes will crack within 8 hours, and the plastics will be microparticles will be released into the circulations, and you will have a rupture of the ECMO circuit and your patient will bleed to death. So usually we use a centrifugal pump. This is the centrifugal pump, and it is attached to a control panel where you can control the rotation of the pump so that you can control the amount of flow it can generate. And the blood pumped to the oxygenator. This is the membrane oxygenator. This membrane oxygenator receives gas from a blender. This blender, here there will be a dial. This dial we can control the FiO2. The FiO2 range will be from 0.21 to 1. That is 21%, that is room air, to the 100% oxygen. And this will be the sweep gas. Sweep gas is amount of the gas we are giving. That is the amount of liters we are giving. That will be given to the membrane oxygenator. After oxygenation, this will be given, this blood will be pumped to the returning cannula. This is the returning cannula which situates in the SVC and RA junction. Sometimes it can be little deep into the RA also. It's not, doesn't matter, as soon as there is enough distance between these two tips, the tip of the drainage cannula and returning cannula. So this is the ECMO circuit that I have been telling. So the deoxygenated bed will be connected. This drainage cannula will have multiple pores, not single pore, so that it can collect the blood from all the sides from the IVC. It will go into the pump. Pump will generate a negative pressure here, and it will generate a positive pressure here because of it is a centrifugal pump. And it will go to the membrane oxygenator, and the gases will go in the membrane oxygenator. The oxygenated blood will be returned back to the RA. In the RA, it will mix with little bit of the SVC blood, and it will, the PO2s will fall further. Here the PO2s are around 300 in the arterial returning cannula. But as soon as it reaches to the RA, the PO2s were went to a 40. The PO2s are around 88, 89. It can be up to 94 also. From here, the oxygenated blood will go into the RV. Usually, deoxygenated blood in the normal people. From the RV, the oxygenated blood will be pumped into the lungs. There is no lung function, but already we have oxygenated the blood and removed the carbon dioxide. The lung will, from the lung, the blood will go into the LA. From the LA, it will go to the LV, and then it will be pumped back into the aorta, and the patient will maintain the saturation. So this is our basic ECMO VV circuits. So the pump, if you say the centrifugal pump, this is the pump. There will be a plate, a disc will be there in that pump, and it will be rotated by magnetically by another pump below it. So as it rotates like this, it will generate a centrifugal force which will push the blood from the to the periphery, and from the periphery the blood will go outside. Sorry. And at the same time it will suck the blood from the top. So blood will come from the top and go to the periphery like this. So this, from this pump, this will go to the your membrane oxygenator. This is a Macket PLS system. There are various types of membrane oxygenator, but most commonly we use this Macket ventilator. There is also called HLS system and also Sorin system. Various different kinds of system is there. So what happens in this oxygenator is that if you see that the blood will come from here and exit from here, but within the membrane oxygenator there will be a small polymethyl pentene tubes will be there. These are around 200 micrometers diameter. If you can compare the size of the RBC to the size of the tubes here. Okay. So within this tube the gas will flow. The gas inlet will be from the top from here. I will show you the gas inlet again. So within this tube the gas will flow. This outside these tubes the blood will flow, and there will be exchange of gases between the blood and the polymethyl pentene tubes. So it will be like this. The tubes will be like this. The tubes will carry the gas, which we call it as a sweep gas. We can maintain the FiO2 of it. The amount of flow of gas we can maintain that based on the flow meter, and the blood will go like this, and there will be exchange of gases between these two, and there will be one more tubings will be there within that system. These small tubes you can see now, that is for the water flow. So you have already seen that hypothermia associated with the CRRT circuit, where you usually rewarm the returning blood up to 41 degrees centigrade, which madam has shown already. But my advice is never rewarm the blood to the 41 degrees centigrade. It will lyse the RBC. Make it up to 39 is okay. Beyond that, if you heat the blood, the lysis of the RBC will be more. So keep a watch on what is, sometimes the direct heat contact tubings will be it warm little more, and if it is like this water flow to a 41 degrees in a membrane oxygenator, it will warm the patient to 41 degrees immediately. So don't do that. Try to maintain it 36.5 to 37.5 degrees centigrade. That is the things you have to maintain. So this is the video I want to show how the circuit will be of one of the ECMO patients we had. So this is the femoral side. Actually it is covered. The cannula will be inside. The cannula will be, tip of the cannula will be at the hepatic vein. From the cannula, the blood will come there. You can see the color of the blood. This is blue color. So experience. See the difference between the color of these two tubings. The upper one is the drainage cannula. The lower one is the returning cannula. You can see the difference in color. So the blood will go like this, and this is our pump. So blood enter from the top like this and exited here, and it enters our oxygenator here now. This is our oxygenator. So the blood will enter the oxygenator. If you see the color difference will be there. Here also you can see this is red color, this is a dark color. So this is the gas inlet will be there. If you can see, I'm showing here the gas inlet into the oxygenator, and these two blue pipes are there. That is the water circulating pipes into this macket oxygenator. So the blood will come outside, and then this is our returning cannula. The returning cannula, we secure it to the patient chest, and the cannula will be like this, and this cannula will go like this and then enter the IJV. Okay, so this is how we do a VV ECMO. So now we have done a VV ECMO. What next we have to do for this patient? So usually if you are able to maintain adequate flow of 4 or 5 liters, we can extubate this patient. We can extubate, and he can talk with you, he can walk with the ECMO, and he can do the physiotherapy with the ECMO. If this patient is a case of ARDS, like in COVID patient, where you had difficulty in ventilating the patient, but it can recover the lung, it acts as a bridge to recovery, but in this case it's a bridge to transplant. So that is this one. How to put next? Okay, this is the console where we monitor. We can manage the RPM of the ECMO pump. So as you can see, this is the dial where you can we can change the RPM. This shows the flow of the. This is the RPM. This shows the flow. So I wanted to show you how the oxygen inlet will be there. The oxygen inlet will be here. So we can take this oxygen from our blender. This is our blender. The blender will have a labeling 0.21 to 1 FiO2, and you can the amount of flow you can sweep gas can be managed from here. You can dial it and keep it whatever you want. The blender receives oxygen and air. The oxygen and air will come to the blender. Here you can maintain the FiO2. Here you can maintain the sweep gas flow. So this is our femoral jugular veno-venous ECMO. Some centers they use the femoral ECMO also, where they are not comfortable. Where one of the patient which I had to airlift also had, they placed, because they don't have expertise, or so they placed only femoral. The surgeon placed it, so they placed only femoral. This is also is okay, but the two cannula should be within the IVC and they should be apart. Usually we don't like this configuration because it will be very uncomfortable to the patient to walk and do the physiotherapy if you have two big cannulas in the femoral veins. So what is recirculation? Usually I have told you that this is the drainage cannula and returning cannula. If they are apart, most of the returning blood will go to the RV through the tricuspid valve. But as the gap between these two tips decreases, there will form a recirculation. The oxygenated blood that comes here goes back again to the drainage cannula, and the drainage cannula pumps back the same blood to the returning cannula. It forms a circuit, and patient effectively there is no oxygenation. It's just the oxygenated blood is circulating in the circuit. So we have to have at least 8 to 10 centimeters of gap between these two. So as I have told you that if you have two femoral cannulas, it is very difficult to walk. Even having a one femoral cannula is also sometimes it is difficult to walk. So what we can do is put a single cannula in the neck and start a ECMO. This single cannula has two lumens, which is a Avalon Elite bicaval cannula. One lumen acts as a your drainage cannula, other lumen acts as a returning cannula. The drainage cannula will have a holes which the distal one will be in the IVC, the proximally will also be there holes, so it will be collect blood from the both SVC and IVC, and it will go back to the ECMO, and the returning cannula will open here. So because of that, it is the jet should be directed towards the tricuspid wall in this. So with a single cannula in the neck, you can put the patient into the ECMO circuit. So you have placed the ECMO in this patient, then you have seen that the saturation had improved initially. Then after some time, this ILD patient, the saturation started to fall, and the BP, especially the BP came to started to fall in this patient. So what we have done, we have checked the X-ray, what is the distance between the SVC and IVC we have seen, but the BP started to fall, and we don't know the reason, but every intensivist should know the echocardiography. So we did an echo. As you can see, this is our LV. This is our LV, this is interventricular septum, and this is our RV. RV is dilated and it is huge, and the septum is moved towards the LV, and the LV cavity is so small. Why this happened? Because these ILD patients, they're prone to develop pulmonary arterial hypertension slowly. So we did that is the TR in this patient. The RV is huge and there is a TR, and we calculated the gradient, and there is a gradient of 96 here between the tricuspid wall. That means RVSP will be right ventricular systolic pressures will be around 96 plus CVP. The CVP in these patients will be around 20. So it will become around 110 of right ventricular systolic pressure. It is dominated the left ventricle. So the septum moved to the left side, and blood is not going to the left side, and patient is not generating enough cardiac output. So what we initially do in this patient is we try to give some pulmonary vasodilators and RV support with the inodilators like milrinone we can use, and inhaled nitric oxide we can use. But eventually these patients may not cope up with the PAH, and the RV may fail in those patients. So what we can do in these patients is we can do a venopulmonary ECMO. What does it mean? That in the venopulmonary ECMO, the returning cannula we placed into the PA, bypassing the RV. So the returning cannula goes from the RV into the PA. So the drainage cannula comes here like this, and the blood gets oxygenated and pumped back to the PA, bypassing the RV. So this is kind of a RV support. So next comes our patient. He is also registered heart transplant patient. So he has been in a list for 2 years. He is a 35 years young male patient, dilated cardiomyopathy he had. So he initially had a heart failure symptoms, then resolved with a Ditor and medications of decongestive medications we have used, and slowly suddenly came with the breathlessness, swelling of the feet, and pulmonary edema. So we have admitted him, and we did an echo in this patient. So as you can see this echo, the LV is huge, and the movement of the LV you can see that it is contracting like this, and RV is also not contracting much. The ejection fraction in him was around 15%. So this is the TR in the patient, and so what we have done to this patient is we initially try the decongestive therapies and try some inodilators in these patients. What happens in these patients is these patients will have very high SVR. Even though the heart is ejecting only 10% or 15%, the stroke volume may be 30 ml, but they will able to maintain their BP because the SVR is very high. But what happens is it is like a pushing against a high wall. The LV is trying to push against a high SVR, and it will form a cycle that low cardiac output will increase the SVR. SVR will cause the low cardiac output. It will form a cycle. So we try to give inodilators in these patients. We started him on a milrinone infusion. That will cause fall in BP. So we started him on RADR to maintain the peripheral vascular pressure again. So this cycle continued, and then we placed him on a IABP machine. So IABP machine will what it will cause the afterload reduction. That is, whenever it tries to contract the heart, it will decrease the afterload by deflating. So we placed him on IABP. So after placing on IABP, he improved for a bit, and then again after 2 days he started deteriorating. The amount of urine output came down, the liver enzyme started increasing. So at this point, what we have to do? So the only we have an option is to support the heart. So how to support this heart? If you even the IABP is not working, the inotropes are not working. So we have to go for an heart lung support here. That is called usually heart support, but that will also oxygenate the blood. That is called VA ECMO. What we do is we take the returning cannula, which is same as before. We try to push it little inside into the RA, so that it will collect more blood, and the blood will be oxygenated and it will be pumped back into the femoral artery here. Okay, so what is happening is blood is coming from here and getting oxygenated, and carbon dioxide removed. Then the oxygenated blood is pumped in the femoral artery, the iliac artery. Then the blood will go in this direction from the iliac artery to the aorta. In the opposite direction it will go, and it will pump till here. But we may not be able to drain this whole right ventricle, the whole blood coming to the right atrium. We may not be able to drain. So, but what we have done essentially is we decongested the heart so that there will be a little function of the heart. So the blood that is returning to the RV, little bit amount, whatever it is, it will go to into the lungs and it will be oxygenated there, and it will come back to the LV and it will pump back. So the blood comes from here, and from the aorta, from the aortic valve, and another set of blood comes from the femoral artery to the aorta, and they will mix here. So it basically maintains the perfusion of the organs, and your organs will get perfused, and the lactate levels will come down, and your kidney starts working and all. This is just a temporary measure to maintain his organs until he has the recovery of the heart. In this case, you have seen it's a dilated cardiomyopathy. It won't recover at all. So we have to wait till the organ comes and we can transplant. Other cases where you have a viral cardiomyopathy patients, where it is a temporary situation. So in these cases, you wait for some time. Slowly the LV and RV function will improve with the steroids, and then you can slowly wean off this ECMO and patient can be discharged. So what is ECPR? So it is a special type of veno-arterial ECMO, where extracorporeal cardiopulmonary resuscitation, it is called, is a salvage procedure in which ECMO is initiated in a patient who you are doing a CPR and you are not able to achieve a return of spontaneous circulation. Thus, the heart is not started beating and it is not started pumping, but you are doing CPR, a good quality CPR. It has been already 20 minutes, but the blood is not coming. Then if you have facilities, you can put a ECMO while doing CPR itself. Okay, that saves the patient. So the inclusion criteria usually for it should be a witnessed arrest, and you should start the ECMO immediate. ECMO should not be started immediately. You should give a sufficient time, up to 20 minutes. You do your efforts of CPR, and at the 20 minutes you conclude that okay, this is the spontaneous rhythm is not coming and the circulation is not established, and then you go for a ECMO. But you should exclude certain people. The very old age people, 80, 90 people placing on a VA mode while doing CPR is not a good idea. And those people with severe malignancies, end-stage diseases, other organs are not good, the brain function is not good. In those people, it is not advised to do a ECPR. So we had a patient of ECPR done when I was in MGM. Actually, I was on duty at that day, but the team went to another hospital where they received a call that we need a CPR, we need a ECMO for a patient with a heart failure. As soon as they reached there, the patients crashed. They immediately did CPR and they started a VA ECMO, and they brought the patient to hospital. And I was on cath lab. The thing was, she was only 36 years old. So what they thought that it could be a coronary event, because 2 days before that she had no symptoms. Within 2 days she had fever, then heart function came down, and then she underwent ECPR. So we brought the patient to the uh, uh, cath lab immediately. We thought it's a coronary event. So the ECMO is running. She is on inotropes. I placed the TE. The heart is not moving at all, and they did a coronary angiography, which showed absolutely normal coronaries, no coronary involvement at all. So we shifted her back to the ICU. We maintained her on ECMO after, and as you can see, you can maintain the the thing with the ECMO is that you can maintain the temperature of the blood and temperature of the patient itself. So we cooled her to the 34.5 degrees to 35 degrees for 2 days. Then she woke up. After that, her right ventricle started improving. Then we placed a impella device. Impella device is a IABP like a device, but there will be a motor at the end of the tip which will sit in the LV that collects the blood from the LV and pumps it to the aorta. So we placed impella in this patient, then slowly weaned off from the VA ECMO. She was eventually on impella, then slowly impella also weaned off after a few courses of steroids because she had a viral cardiomyopathy in this patient. So during this time, the organs which got hit was kidney, actually. So she went into AKI, required multiple, initially CRRT, then intermittent hemodialysis. After 2 months, then I changed the hospital. So till that only I know she got discharged, but she was on intermittent hemodialysis. Okay, so that is our VA ECMO. So I have been so in this VA ECMO, as you can see that there is some amount of blood going into the lungs which is getting oxygenated and returning back to the LV and pumping into the aorta. What happens if he gets a VAP, ventilator associated pneumonia, and this lung stops working? So what happens in this patient is that this deoxygenated blood will go to the into the lungs and it will return back to the LV, and it won't get oxygenated. This deoxygenated blood will be pumped into the aorta. So as you can see, the major blood vessels to the brain and coronary arteries are supplied by this. The deoxygenated blood will go to the brain, but if you put a pulse oximeter here, it will show 100% oxygen because this part is receiving blood from here, the oxygenated blood. So it is like this, which we call it as a Harlequin syndrome, north-south syndrome, or differential hypoxia. So the deoxygenated blood is getting here, and you will get the cerebral ischemia. You will get a coronary ischemia. If it is a temporary phenomenon, because it is getting coronary arteries are getting deoxygenated blood, it won't recover at all. So how will you know that there is a Harlequin syndrome? First, you have to suspect. We will know that there will be, if RV is completely emptying by the drainage cannula, the aorta flow will not be there. So in that time, the arterial waveform will be a flat because the centrifugal pump will flow the blood in a continuous flow. It will not like our heart, like arterial waveform will not come. It will be a flat. If you are seeing a arterial waveform, that means that heart is pumping certain amount of blood. Then you have to confirm that this blood is getting oxygenated. So you should see how the lung parameters are there in our ventilator. Is the lung parameters are requiring low pressures and all. So other way to see is that you put a pulse oximeter on both the limbs and see if there is any difference. And you can put a NIRS monitoring on the head if there is any difference between the two sides. Sometimes the point of intersection can be variable. It can be point of intersection of these two blood can be here, anyway. If you are here, you can see there will be a difference in NIRS monitoring in these two parts of the brain. So how to mitigate this one? Whenever you suspect some amount of the lungs are bad in these patients, you have to take a Y loop, Y junction from the returning cannula and put it back in the RA. Either you can go from the jugular side if it is difficult for you, or you can go from the same venous side or opposite venous side. You can go and give this little bit of oxygenated blood into the RA. This oxygenated blood, because the saturation will be more in this and the PO2s will be more, it will mix with that little bit of venous blood, and this will get some amount of oxygen into this blood. Even though it is not get oxygenated, it will give the oxygenated blood into the coronaries and the brain. ECMO and AKA. So the incidence of AKA in ECMO patient is around 40 to 50%. So out of this 40 to 50% of the people, Again 50% of that will require some amount of renal replacement therapy. So to start a renal replacement therapy in a ECMO patient, you already have so many cannulas in so many vascular lines. You should have a vascular access. If it is only two, like femoral and IJV are used, you can use the other femoral artery for a dialysis catheter. But what we usually use is we put this other extracorporeal replacement therapies in the ECMO circuit itself, because it's already pumping a blood of 3 to 4 liters of blood. Taking a 250 ml of it per a minute is not a big deal. But where to put that connection? So what's happening? I hope you can see the image. This is the pump, this is our drainage cannula, and this is our returning cannula, this is our oxygenator. So the pump is actually centrifugal pump. So there will be a negative pressure will be built up in this. The negative pressure will be around minus 100 millimeters of mercury when it is in the open. But when you clamp that line, it will be up to minus 300 it can go. And there will be a positive pressure buildup will be there here. This positive pressure will be around plus 200 to plus 300 millimeters of mercury. Okay, so what we want is whenever you are putting in oxygenate this renal replacement circuit, we don't want any clot or any air bubble to go into the arterial system so that it will embolize to the circuit and go to the brain and cause ischemia. So always your returning cannula should be the hemodialysis, the renal replacement returning should be pre-oxygenator. That means before oxygenator itself, your blood should return, so that whatever the emboli is there, that will trap in your oxygenator. Even though oxygenator life will decrease, but the patient will be saved at the end. So where to take the access port, you can take anywhere. You can take just after the pump, or you can take just after the oxygenator. So this is the oxygenator. But most important thing is your alarms. So because the pressures initially itself will be plus 200, you should manage your alarms and set your alarms accordingly. So this is the circuit. Here is one of the renal replacement therapy. Here we have taken a access from the post membrane and returning back to the pre-membrane here. The other example is that take both of them in the post membrane, post pump, but always returning cannula in the pre-membrane. Okay, don't put your access from here, because there will be a lot of negative pressure, minus 100, and your roller pumps may not be able to pump that blood into the CRRT circuit at that pressures. So that concludes extracorporeal membrane oxygen thing, that I have told you how you have to manage a VV ECMO patient, how respiratory failure, how we start an ECMO, and then VV ECMO, how we converted that VV ECMO to veno pulmonary ECMO, and how we placed a VA ECMO in a heart failure patient, and ECPR I have told you, and how we converted that VA ECMO to VVA ECMO, where we have taken a side limb to the right atrium. So this concludes our extracorporeal membrane oxygenator therapies. Now we have a extracorporeal CO2 removal techniques. So in the extracorporeal CO2 removal techniques, as you can see, the application here they have given as a lung protection. So how this is started? Actually, I have never used, and I have never seen anybody using the extracorporeal CO2 removal also, but there is a simple technique only. It's like a ECMO only, but the principle here is important to understand. So they started like a lung protection. When the ARDS protocol came, they started trying to protect the lung from the barotrauma, volume trauma and all. They started giving a low tidal volumes to the patients. So they gave a, like initially they said that 6 to 8 ml per kg. They should not go beyond 10 ml per kg. Then the guidelines came 6 to 8 ml per kg. Then they say that permissible hypercapnia. You allow the hypercapnia to build up, but give low tidal volumes. Go for less than 6 ml per kg. Then came the concept of ultra low tidal volume ventilation. So what they tried to do is they kept a high PEEP and the plateau pressures they kept low, so the pressure driving force will be less. That will give you only little amount of tidal volumes, that will be around less than 4 ml per kg body weight, but it will maintain the saturation of the patient at the expense of build-up of the CO2. So what we have to do to remove this CO2? So So actually, the main difference between the ECMO and extracorporeal circuit is that you can manage the ECMO and ECOR is that you can manage ECOR with 500 ml of blood flow, but you cannot manage ECMO with that much flow. So why we can't manage ECMO with 500 ml of blood, but we can manage ECOR with 500 ml of blood? That comes to this formula of oxygen carrying capacity of the blood. So if you see the oxygen carrying capacity of the blood, it is given by formula 1.34 into hemoglobin into ratio of saturation of the blood to the by 100 plus 0.003 into PaO2. What does it mean actually is that if your saturation is 100 and your hemoglobin is 15%, you will maintain that blood, the 100 ml of blood can carry 20 ml of oxygen. And the extra dissolved oxygen will be 0.003 times of the partial pressure of the oxygen. So whatever may be the partial pressure of oxygen you increase, the dissolved oxygen will not increase. Let's say your partial pressure of oxygen you increase more than our atmospheric pressure, like 1000 you increase, but the amount of oxygen that will increase per 100 ml will be 1 ml only. So it is the arterial content will carry a maximum of 20 ml of blood per 100 ml or 200 ml of blood per liter if your HB is 15. And mixed venous saturation, if you calculate the oxygen content in the mixed venous cannulation, it will be a 15 ml per deciliter of blood. The saturation will be around 75% in the mixed venous. So the oxygen requirement nearly the difference of 5 ml per deciliter of oxygen will be used every time. So the patient adult really requires 250 ml of oxygen per minute. So to provide that 250 ml, per 100 ml you can provide only 5 ml of oxygen. For 250 ml you will require around 5 liters of the blood to flow. But that's not the case with the CO2. The CO2, most of the CO2 will be in the bicarbonate form or in the dissolved CO2 form. So in a 75 ml, 75 kg patient, the 1 liter of blood can contain at a normal pH 600 ml of CO2, and we can decrease the partial pressure of CO2 from 46 to up to 5 in those patients by washing out the CO2 with the air. Where you maintain very high flow of air, the CO2 will be washed out. So it can remove theoretically up to 600 ml, but that is not possible completely. But but we can maintain up to like 250 ml we can remove. So with the 500 ml of blood, we can remove a 250 ml of CO2. This is the amount of CO2 that is produced per minute in an adult. So with this, the blood is returned back to the circulation. The 250 ml of CO2 per minute is removed just with the 500 ml of circuit. So that is the main difference. But this is like this only, the same oxygenator circuit, but here we will have a high VQ ratio. Ventilation will be very high, but the perfusion will be very low, so that the CO2 is completely washed out, but you won't be able to maintain the oxygenation, only the CO2 will be washed out. So where can we use this patient? That I have told you already, that where you want to use a very ultra low tidal volume ventilation, but in the studies they did, they were not able to achieve that tidal volume with this. They were like that. The target was to go up to 3 ml per minute, 3 ml per kg body weight tidal volume to prevent lung injury, but they were able to achieve around 4.4. So nowadays they are not using this for the ultra low tidal volume ventilation. They are using it as a rescue therapy in patients with COPD, where there is only CO2 retention is there. Okay. So these are the various pump the ECOR pumps that are available commercially. As you can see, the pump flows will be very less, that 400 ml, 500 ml, like that will be there. Okay. That's it. If you have any questions.
Thank you, Dr. Vamshi. You have elucidated very well regarding the extracorporeal membrane oxygenation and also extracorporeal removal of the carbon dioxide. Majority of the nephrologists know how to remove the uremic molecules, but you rightly showed how oxygen can be absorbed and carbon dioxide can be removed. So the question that I have is, what happens to the oxygen dissociation curve in ECMO and also in the other carbon dioxide removal form? like you know about the Haldane effect and
Yeah.
Bohr effect. So how these curves are maintained in the ECMO? So how much partial pressure that we are able to maintain in the ECMO, like in
See, the main important thing in an ECMO, when you are initiating a patient in a ILD, those people are usually used to a CO2 levels of 70s. So if you start an ECMO, usually we maintain sweep gas flow, which I have told you. That will be the flow of you have a pump flow usually around 3 to 4 liters per minute, but based on the body weight and requirement, we can go up to 7 liters also. We try to maintain the sweep gas flow ratio to the blood flow ratio as 1:1. That will give you a CO2 of around 40 to 46, but it's not always true. We have to monitor the patient ABG, and we have to manage the sweep gas flow according to that. But whenever you initiate a ECMO in a patient with a CO2 of 80, don't try to come down CO2 to the 40 levels immediately. That will cause acute cerebral vasospasms. So don't try to start with low sweep gas flow. If you are starting at 4 liters of blood, you start pump flow, you start a sweep gas flow of 2.5, and check is arterial blood gases and see how the CO2 is. Try to, if you suddenly compensate, make the CO2 normal people, which is normal to us. So there will be a sudden alkalosis will be there, respiratory alkalosis will occur, and cerebral vasospasm. So you try to slowly increase the sweep gas flow. So the in this patient the bicarbonate levels will be very high. It tries to compensate. So we have to come down the bicarbonate levels also. Again, we had to readjust. The kidney has to readjust for the new CO2 levels. So try to come down very slowly over 24 to 48 hours. Then you try to come down to, even if it is a CO2 is 50 also, accept it. Don't try to overcorrect it.
so
So for simplicity's sake, as a nephrologist, if I ask you that the real indication for this ECMO is a kind of hypoxia which is not getting corrected despite ventilation for heart failure or for a lung failure, and carbon dioxide removal is an experimental therapy at the moment, may not be required as per.
So carbon dioxide therapy nowadays indications are not there nowadays. The main indications, mainly we use a ECMO. ECMO only we use further. But we can use, it's like a, why you, before you initiate an ECMO, you should have a clear plan. If I initiate ECMO in this patient, what I have to do next? So because ECMO itself is very costly, the initiation itself takes around 7 something, and then you have to, until the patient recovers or gets a transplanted, that many days he has to be on ECMO, and every day is a cost. That if the donor comes after 3 weeks, I have seen patients on ECMO for 150 days like that. So if the donor doesn't come till 150 days into amount of money that comes each day, that much money they has to pay. So it's very not a good thing. So before initiating, you should have a plan. What we are going to do with this patient, whether this lung will recover or not, whether this heart will recover or not. What will we do if heart won't recover? Because in the people with dilated cardiomyopathy who are waiting for the transplant, it won't recover at all. But in people with cardiomyopathy, or there is some acute event, some acute myocardial MI, you revascularized it, then the slowly heart may improve. So it depends upon how scenario will develop. We should have a calculation in the mind, and before initiating itself, we have to discuss all these things with the patient, and we have to discuss the problems of the ECMO. Like in these patients, I have not discussed every detail of how you manage the anticoagulation, how you manage the infection, how you maintain the circuit, how you monitor various pressures in it, because there won't be enough time to explain it. So these people will be maintained at a anticoagulation level with a APTT between 60 to 80 seconds with a heparin infusion. Usually we use bivalirudin infusion, direct thrombin inhibitors. So how frequently you have to monitor, what are the complications. We have lost patients to intracranial bleeds, gut bleeds, and sepsis. Sepsis is one of the most common complication, because you can see the size of the cannula. Size of the cannulas will be around 25 French, 29 French cannulas will be there in the groin. So your dialysis catheter will be 11 French or 13 French maximum. This will be around 29 French cannulas. And what I have discussed totally is a peripheral ECMO, where you cannulated very cleanly in the neck and groin. But we do use the central ECMO, especially in the post-operative patients where we already done the sternotomy and there is already cannula in the aorta directly. So what we do is we take the cannula just below the diaphragm episternum and we close the chest. This is the central ECMO we call it. So in this patient, the amount of infection you see and the sepsis you see is sometimes you lose patients to sepsis, I would say most of the times.
Actually, indication-wise, the indication should be proper and judicious uptake of the patient should be there,
Yeah.
because we have seen patients who kept on Impella for heart and CRRT for kidney and ECMO for lung. Like all the organs are being supported. Patient had came out, but actually succumbed to the infection. Everything was done, but ultimately, as you said, patient succumbed to the infection, that's all. He came out of the Impella, they done IABP, Impella was done, IABP was done, stenting was done, then patient kept on CRRT, then again IABP was kept, then ECMO twice. So, but ultimately, patient came out actually, then after that he succumbed to simple infection. As you said, he had a groin, big,
Absolutely.
initially hematoma was there that got into sepsis, and patient come to this, succumb to the sepsis. So, taking up the patient in a judicious manner is very, very important when we are trying these high-end therapies. Though technology is available, but right indication or for a right patient is a must if at all we are trying to cater to many number of patients. Yeah. Any questions? Yeah.
Yes. Yeah. Actually, you have to. You should use a roller pump. Sir. You have a roller pump in CRRT. Yeah, that will be sufficient for the pressures because the pressure gradient between the oxygenator will be around 20 to 30 minutes. Yeah. That will be only same blood will come, but it does.
Amount of flow which you take for CRRT is hardly 150 ml per minute, and as we showed, the flow in the ECMO is one cardiac output. It's around 4 liters. So the amount of flow you are taking is very, very tiny. So recirculation is insane. Thank you, sir.
Yeah, thank you, Vamsi. It was a very nice talk. And in fact, as a nephrologist, we are tuned to put catheter. I was little shocked to see the cannula which we use. As you said, it's almost 4 to 5 liters per minute, and our catheters generate only 250 to a maximum 300 400. So it was actually even as a nephrologist, I was shocked to see that catheters putting procedure when catheters was being placed. So that's one thing. And the second thing I wanted to ask, we discussed this as a bridge therapy and as a resuscitation measure. But what is your take on using this ECMO in the deceased donor transplantation?
Okay.
The deceased donor transplantation, the donor part, not the recipient. You are talked about the recipient as a bridge therapy,
Yeah, there
as
is
a donor.
see, we haven't done the ECMO in the. There are extracorporeal circulations that are used to preserve the organs. So in other we don't do it in our country. In other countries, in a patient with a brain dead patients, they do place ECMO to preserve the organs so that the donor organs, those organs can be used for a other patients. And apart from that, there are some extracorporeal circulation that we are researching already, one which we call as a ex vivo perfusion of the lungs. We take the lung, and after taking the lung, the lifespan of the, once you take out the, you give the pulmoplagia solution to the lung, and after giving the pulmoplagia solution, we have a time gap, a time, like your clock starts ticking. Within that time, you have to transplant the organ. And the most difficult transplant I have seen is the only lung transplant. Heart is very easy, I think. So the lung transplants, so we sometimes we get an organ, we don't know whether it's due to fluid overload or not. Sometimes it's just the fluid overload, or sometimes it can be infection. So sometimes it's very difficult to say whether this donor organ is can we transplant this organ to the recipient or not. So what we do is we ex vivo perfuse that lung. So we take the cannulas, we put the cannulas in the pulmonary artery, and LA cuff will be there. From there we drain it. We create only lung will be there, all the other organs are removed. That we perfuse it, and we try to take out some volume out of it during that also, and see the X-ray. We can take the X-ray of that lung only whether it improves, and we can take samples from multiple pulmonary veins and see the how oxygenated improve. That is a ex vivo perfusion we call it. And you might have already heard heart in a box, where the beating heart will be there, it will be perfused and it is transported to some one location to other location, and that heart can be transplanted again, giving the cardioplegia, and then transplant, and again reperfuse, and we can start the heart. But ex vivo we are doing some research, but the heart in a box we are not doing as of now.
Thank you, sir, for such an informative session. I would like Gangadhar sir and Jha sir to please join for a group photo. Next up, we have our esteemed speaker, Dr. Valentine Lobo sir, with the topic Hemodialysis Technology Demystified. I would like to call Dr. Swarnalata ma'am and Dr. Manisha Saha ma'am on the stage as chairpersons for this session.